Are we ready?
I'm ready, but I don't see my slide deck.
Yeah, I don't see any slides yet either. Okay.
Okay. There
Great.
we are.
Good evening, everyone. Thanks for joining us for our CIS Case Conference webinar series for the month of February. My name is Andy Snow. I'm at Uniform Services University in Bethesda, and I'll be one of your co-moderators this evening, along with Dr. Joyce Yu at the Morgan Stanley Children's Hospital at Columbia University Med Center. So I just want to thank LACID and USIDNet, as always, for their generous support of the webinar series. And before we get started into the two very intriguing cases we have tonight, I just want to remind those of you in the audience that we are always looking for new and interesting cases to present in this webinar series. It's a great forum for getting feedback and ideas from your colleagues. And for those of us who've joined in tonight, please feel free to offer your questions and comments as each case is presented through the chat box on the lower left-hand side of your screen. So with that, we'll jump right into the first case, which will be presented by Dr. Elena Hsieh, who's an assistant professor in the Department of Immunology and Microbiology at the University of Colorado, Denver. And we're very lucky to have Dr. Kathleen Sullivan, the chair of the chief of Allergy and Immunology at Children's Hospital of Philadelphia, who will be our senior mentor for that case. So without further ado, I will turn it over to Dr. Hsieh.
Thank you. So this patient, I actually just met in the last year, and many things happened before I met her. So I'm going to try to give you the best summary I can of her illness. So she is a 11-year-old girl with a history of severe bronchiectasis, which started when she was about 7 months old. So I met her in May 2016 when she was 10, and at that point, from a respiratory standpoint, she's basically on O2 supplementation every night and on a fairly complex CF-type respiratory regimen. She has had poor growth for most of her life. She was diagnosed with celiac disease about 4 to 5 years ago. And at the time of admission, she came in with an issue with having bloody diarrhea and electrolyte abnormalities, which was new for her. She had never had this type of presentation before. And they consulted immunology with the question of whether there was an underlying immune deficiency that may tie in together her pulmonary pathology as well as her GI pathology. So a little bit of her past history. She's the only child to this family, was born full term. There were no issues, and for really her first 7 months of life, gained weight and developed appropriately. Started around 7 months of life, started getting multiple hospitalizations, all for respiratory reasons, either trouble with the work of breathing, having persistent cough, fevers, and then pulmonary got involved at that point. That was in 2008, and she had a fairly hefty pulmonary workup. She had a sweat test for CF, and that was normal. They pursued genetic testing for CF, and that was also normal. She was evaluated for PCD with a nasal biopsy, and that was normal. She was checked for alpha-1 antitrypsin, and that was also normal. And then they performed an open lung biopsy in March of 2008, at which point she was 2 years old, and the impression on the pathology was cellular bronchiolitis with focal organizing pneumonia. And what they saw, they essentially saw lymphocytic infiltration that was mostly CD3 positive with a few CD20 positive cells, with focal destruction of the mucosal surface. There were a few macrophages around the alveoli, and there does not seem to be evidence of vasculitis with lack of involvement of the vasculature there. At the same time, she also, because was having trouble growing, they decided to pursue also a GI biopsy. And the duodenal biopsy showed that there was a villous abnormality, not quite the traditional villous atrophy or villous blunting that may be seen on celiac, but they said it was consistent with celiac with a MARSH score of 3A. She did have some lymphocytes in the epithelium and lamina propria. Her chest CT showed fairly extensive bronchiectasis consistent with her lung biopsy. Around that same time, in addition to the recurrent pulmonary hospitalizations and poor growth, she also started to have some vasculitic lesions. These were non-pruritic, they were purpuric looking, they were blanching, and since she was going under anesthesia for biopsy, then they decided to take a skin biopsy too. And that showed superficial dermal lymphocytic infiltrates that they said, well, we can see this in chronic dermatitis. So they started her on a gluten-free diet around this time in 2008, and she was still having problems growing 6 months later. So the biopsy, the first one was in February. So they did another biopsy, this one more extensive, including stomach and rectosigmoid area. And the stomach one showed that there were several lymphoid aggregates, but there was no H. pylori. And then there were also lymphoid aggregates in the rectosigmoid area, but there were no granulomas seen. So at this point, she went on in this year with, this is sort of like her big workup year. She started the CF pulmonary regimen and eliminated gluten from her diet. And I will pause here before I move on to the next one.
Yeah, thanks, Dr. Hsieh. So I think now that we've seen a bit about the initial presentation, it's pretty intriguing, right? So we have severe bronchiectasis, lymphoid infiltrates, clearly enteropathy. But before we move on to the immunological workup, I thought we'd pause for any questions at this point from the audience. We have one from Dr. DeBrooker in Edmonton. Any plasma cells present in the infiltrates?
So this was not commented on the report initially, but we spoke with pathology, and they say just the same way they can see a few CD20 positive cells, they can see a few plasma cells.
Okay. Any other thoughts from the audience at this stage?
Elena, this is Kate. Did they know, so if there are not many CD20 positive B cells, are these lymphoid aggregates primarily T cells? I was thinking that they were B cells, but based on what you just said, I guess they're probably not. Do you have a sense of what they are?
So in the lung, we know that they were CD3 positive. For the GI biopsies, these are from 2008. They did not stain for CD3 or CD20. In the lung, there was a specific request for that, and that's why they stained for it. For the GI biopsy, there was no request, so I do not know. We could at this point ask pathology to see if they could retrieve those to stain that, and we have thought about doing that, but at this point, I don't know.
We have a question about, was there any consanguinity in the family?
Not that the parent is acknowledged.
Okay.
The parent, yeah.
Elena, were there any cultures done on sputum or anything like that?
She has had multiple cultures from sputum, and she has had multiple BALs.
Right.
And she has grown a lot of the organisms that you would see with a CF patient. So she definitely has Pseudomonas. She has had a Stenotrophomonas. She has had Haemophilus influenza. Let's see. That's what I recall from her culture. She has never grown any. I specifically looked, and believe me, between 2008 and now, she has had multiple cultures.
Right.
She has never grown fungal organisms. She has never grown mycobacteria.
Got it.
So those two things I know. Yeah.
Okay.
I just want to comment on this posting by Amit Rawat from India, who just took a guess at LRBA and CTLA-4 deficiency, and I think the rationale for that is this sort of combination of villus atrophy, lymphoid aggregates, and the classic lung disease. And that combination is certainly very suggestive of LRBA or CTLA-4 deficiency. I think it also could be consistent with some of the PI3 kinase defects as well.
Right. Yeah, it's definitely.
Jack Rudishay, the thing is with the lung disease that you see with CTLA-4 haploinsufficiency, it isn't typical to see biopsy that was seen here. You're looking at a predominantly CD3 positive biopsy. There's no granuloma. There's no follicular bronchiolitis. There's no LRP. There's no granuloma. There is organizing pneumonia, which you see in CTLA-4 haploinsufficiency, but the biopsy itself is a little odd, for that.
So can I ask a question along those thoughts of LRBA, CTLA-4, PI3 kinase? In those cases, the lymphoid
entry and exit chimes are off.
The lymphoid aggregates are CD. You would expect them to be CD3 positive. Is that correct?
So,
hello?
To my knowledge,
for the
PI3 case, no. You get so the lung disease with PI3 kinase is what I've seen so far is predominantly structural. In other words, it's bronchiectasis. With LRBA, CTLA-4, and a variety of other monogenic defects, you see either GL-ILD or a variant of GL-ILD. You see follicular bronchiolitis, LIP, and granuloma. So I'm not aware of, anything's possible, but I'm not aware yet of that GL-ILD being described in PI3 kinase. And the description of the path here is weird because it doesn't really fit that either. It doesn't fit GL-ILD.
Right.
Yeah.
We have a few more questions from the audience. Did she improve when gluten was removed from her diet?
No, and that was measured. So the main concern at that point, so I want to say that the diarrhea and the sort of malabsorptive issues were new and started in 2016. She did not have that before. She was able to eat by mouth, no problem. And the concern before 2016 has always been the poor growth for her in someone who consumes calories, etc. And the gluten-free diet did not help with the growth. She really never had the skin findings for somebody with celiac, and she also never really did not have the positivity for the classic celiac panel in terms of autoantibodies.
Okay. And were there any bone abnormalities noted?
No bone abnormalities.
Okay. So I think let's go out and move on to some of the immunological workup, which will get to some of the additional questions we're getting.
Okay. Let me see. Okay, here we go. So actually, between 2008 and 2012, she was under the care of pulmonary and GI. And then around the year of 2012, hematology got involved, and a immunological workup was pursued at that point. So this is sort of the first time she gets evaluated from an immunological perspective. She had a dihydrotamine stain, looking for CGD that was normal. She had complement studies with a CH50 that was normal and a AH50 that was low. She had a TLR function assay that was normal. She had neutrophil, bactericidal, as well as chemotaxis assays, and she had several of those. So, this is all me looking retrospectively. So, I'm telling you what I was able to find. And there were some reports that were normal, and some reports that were abnormal. And under the care of hematology, she was initiated on interferon gamma, sub-Q 3 times a week. And she's still currently on that, actually. And there is, when you ask the family, there has really not been a decrease in the number of hospitalizations or pulmonary infections that she's gotten since she's been on this therapy. She's still in and out of the hospital once every 2 months between 2008 until now, mostly for respiratory reasons. I should say that when she was first diagnosed around that time, 2008, they did have her on a high-dose IVIG plus steroid pulse regimen, sort of traditional pulmonary regimen once every month, I believe. The family acknowledges that maybe that helped for the first 4 months, and then it really hasn't helped since. She then went off the high-dose IVIG, and she has been chronically on steroids some way, shape, or form, not at a pulse dose, but always to some degree. She had, at that time, normal vaccine titers for diphtheria, tetanus, and Hib, and when I look back at her labs, like her ESR, as far as I can look, it's really always elevated. The lowest I've seen it is probably high 30s. Mostly she hovers between 50s and 100. And then I'm showing you now sort of her T cells and B cell numbers. So she has had lymphocyte enumeration done multiple times between 2012 and now. And you can see her numbers and her progressive decline. She now, most recently, she's actually currently hospitalized. She lives in Kansas, so they're not in our center. And I was able to get a hold of a CBC, and her white count, her total white count is 1.5 at this point. I don't have a breakdown with me. But you can see that she's had progressively dropping CD4 counts as well as dropping B cell counts. Then you can see that she's had lymphocyte stimulation assays done multiple times as well. Initially in 2008, the response seemed to be good. Then in 2016, when I met her in May, she had no antigen response, normal tetanus response. And then in October, she had no antigen response. Since the time that I have met her in May, in terms of therapy, she was hospitalized for the GI issue. She actually has a G-tube and she was getting some feeds. Then she's now actually on TPN because she can't get that amount of feeds. She then has diarrhea. So she has to be on TPN overnight. She still eats by mouth, but really the TPN helps with the weight. She has been on Imuran. That did not seem to help. Then she has moved on to Celcept. So she's currently on a CF regimen on Celcept and has been on a waning dose of steroids. The immunoglobulin levels, those actually have remained fairly stable. So you can see her IgA, IgG, and IgM levels. When I met her in May, I did repeat the AH50, and at that point in May 2016, it was 0. And then she had a workup by rheumatology. And they basically ordered a battery of autoantibodies in the last year, and she was negative for all.
Okay, well, we've got several more questions from the audience. Were IgE titers ever measured? Was one thought about hyper-IgE?
Yep, she does have an IgE. Sorry, I didn't include it there. It was normal.
Okay. And were there, in the phenotyping workup, were naive versus memory T cells quantitated in any way? We see the progressive CD4 lymphopenia.
Mm-hmm. Yes, they were. They were done once in May, and I believe they were normal. I'm just double checking on that, but I'm fairly certain they were normal.
And then we also have a
so
question.
That has only been done once, yeah.
Okay. And then we also have a question about some additional blood tests, serum vitamin B12, soluble fast ligand. Maybe the thought is ALPS there. Were those ever?
No, she has not had a vitamin B12, or she's definitely not had a fast ligand. I don't think she's had a vitamin B12.
Okay. So we've had a few more suggestions in terms of a genetic etiology. RAG1 was proposed by Dr. Rawat, although the B cells seem to be okay. But the progressive, go ahead.
The B cells have definitely had a decline over the time Elena has been measuring them. They're not as dramatically diminished as the T cells.
True.
Oh, a question. What about gain of function STAT3? Have you looked at the Tregs to see if they're normal?
And good question. I don't think I have looked at Tregs by flow.
I mean,
I'm pretty sure I didn't.
There's a lot of
stuff
here that goes along with it. Variable T and B cells that can decline, enteropathy, lung disease. It certainly could be consistent with that. And presumably the Tregs are abnormal when you screen with a gain of function STAT3.
One of the really consistent features for STAT3 gain of function is that the people who carry that defect are quite petite. So usually the adults are less than 5 feet. The kids are well off their growth curve. So that can be helpful. I don't know that it's seen 100% of the patients, but certainly it's a commonly described part of the phenotype.
And this child is small, right, Elena? Or did I?
Yes, she's pretty small. She's pretty small. She was evaluated by endocrinology, who thought she was a candidate for growth hormone. I'm trying to remember now. Can I ask a question about the STAT3? So my understanding also is that often the STAT3 gain of function tended to have hematologic involvement. I know she does, obviously not everybody is am I along the right lines, or is that not correct?
I don't know the numbers. Not my memory. My memory is that it tends to be solid organ inflammation with liver, GI. Maybe some of the patients do have autoimmune cytopenias. That hasn't been true for my patients.
Okay.
At least Josh's series, the Milner, a lot of those patients had autoimmune cytopenias and thrombocytopenias.
Yeah.
Right. Elena, were there anything remarkable with regard to the rest of the CBC? Did you have a low platelet count, anything like that?
No. So she actually, those numbers are pretty normal for her. She's not really being, she's not someone who's being Coombs positive anemic. She's not someone who's being thrombocytopenic. So that's been pretty normal for her.
Well, we've had some great comments. I think in the interest of time, just so we can make sure we get to the other case as well, let's keep going with some of your exome data.
Yep. So, she then again, she's got another GI biopsy in October 2016 because things were not getting better while she was in Imuran. And you can see that she has, again, a blunted villus architecture, and she does have lymphocytic infiltrate. And she had BALs multiple times. This is sort of the most recent one, and you can see the breakdown of the cells that we see there in the BALs. In 2015, her vasculitis skin lesions came back again, and then she actually had a clot. So they did another biopsy, and this time you can see that there was the perivascular inflammation with neutrophils consistent with early vasculitis, and she was actually started on aspirin for that reason. So I think everybody has been alluding to some of the disorders in which really, if we wanted to make the diagnosis, we will have to go to whole exome sequencing, as we don't really have nice panels to include all the things that people have suggested. So we did that. We did it through a CLIA lab with GeneDx, and then to all of our surprise, this must have been the shortest report I've ever seen. There were literally 3 lines with no chart of any kind, and he said no pathogenic variants, no variants of unknown significance, like not even AVUS. So that's what we got back from GeneDx.
That's crazy. Yeah.
That is absolutely impossible.
I know. It made me want to cry a little bit.
I mean, you can't have. It's impossible.
I'm with you. I'm with you. I then sort of went back to GeneDx, and I first talked with them, and I said, well, this is the report I've gotten. I am beyond shocked, but can you do me a favor and take a double look at these genes and tell me what the coverage and the depth is? And I gave them, it gives me some comfort. So I didn't ask for STAT3. But it gives me some comfort that some of the things you said I asked for. So I did ask for CTLA-4, LRBA, PI3K, STAT5B, and they told me that they were very well covered, over 90%, and that I now cannot recall the depth, but really that most of the exons were covered. So that's what they said. Then we did ask for the raw data to analyze it, and I just recently got that and worked on it with a bioinformatics colleague here. And I again asked her, this is my list of top 10. Can you look for those? And she combed those pretty well, and she did say, yep, these are pretty well covered, and there was nothing in those. But then we talked about sort of what were the filters to apply, what do we want to look for, and then she sent me a pretty long list. This is the short version of the list with some of the things that I felt, were probably potentials in the sense of, okay, are they de novo, and is this a bad mutation, meaning, rare, not public, not private, predicted by polyphen to be detrimental. So we looked for a couple of these. I must say that I'm not sure that any of these make that, fit her picture. So I don't know if you can see my arrow here, but these are essentially NK cell receptor defects, and she's a compound hit in basically one from mom, one from dad, and they are very rare mutations in a pretty well-conserved area. I can't really fit for her picture with an NK cell defect myself. And then this one is a de novo mutation, a really, really, really rare, predicted to be really bad mutation. And this is an enzyme that is a cousin of GALANT2, which is involved, I believe, in mucin metabolism. I can double check that. I just got this like 2 days ago. But nothing that's very immunological per se.
Yeah, definitely a puzzle. We're getting fairly late here, and I know there's some comments about, so obviously the genetic diagnosis is sort of TBD, but in terms of treatment, you mentioned she's hospitalized now and in pretty bad shape. We have one question regarding stem cell transplantation, whether that would be considered at this point, or what are some other ideas about treatment options, I guess, from our mentors or the audience?
So this is Kate. So when Elena and I were speaking about this case, she said one of the things that had been really frustrating to her is that one of the very consistent laboratory features is very low age, 50. And was that telling us something? And, the alternative pathway complement deficiencies don't really have this phenotype. there are these two reports of an autoinflammatory type syndrome associated with factor I deficiency. And when I first read those, I thought those were sort of red herrings. But Troy Torgerson, who thinks quite deeply about things like this, thinks that they may well be real and that there may be this alternative phenotype associated with factor I deficiency. And, you know, there's a lab at National Jewish that'll sort of parse through the components to see whether there might be a missing factor I. It's hard to put together with this whole exome where there weren't any variants picked up. But it's sort of one thing to hold on to, and it's the one thing that's sort of weird about this story is this very, very low age.
Yeah, that is the one thing that I think has been consistent throughout. And even when we look back at before she was on any immunosuppression, the sort of very first immune workup she got, that is the thing that has been consistent. So I think it's a great idea. I am now fairly distance-wise close to the NJ lab, so I could talk with them about complement assays and dissecting that a little bit more.
And one of the reasons I mentioned it is you were asking about therapy, and I think a lot of people in the chat box are sort of saying, well, you know, would you go to transplant for this? It feels like sort of an immune dysregulation syndrome. Would you, even without a gene defect, think about going down that path? I don't know about your transplant group. Ours would have, I think, a tough time swallowing this as a reason for transplant, but I think they could potentially be persuaded. What have you thought about that, Elena?
Yeah.
Is that on your horizon?
Yeah, so I thought about that, which is why I've sort of kind of gone through, look at this more and more and digging in the whole exome data more because, frankly, I would be pretty scared and concerned about transplanting her where I can say it all smells to be immunologic, but I don't really have proof of that. And while I agree, I think that our team will be approachable about this. I would sort of say the same thing that you've said. I think they wouldn't be thrilled about it, but they could be, quote, be talked into it. But I'm not sure that I can even talk into it when I myself, I'm not confident that that is the right thing to do. And it may just be because I'm scared because how bad is the lung disease? It's really, it's pretty bad. It's bad.
Yeah. I mean, you might consider broadening the immunosuppression or trying a biologic like tocilizumab or something like that and see, you know, I mean, her SED rate's high all the time, her CRP's high all the time. You know, what do you have to lose at this point by just broadening the stuff that you give a shot to?
Right.
Yeah.
Well, Elena, I think just to, you know, in the interest of time, I hate to cut you off. I think we could probably talk about this case another hour, but it's very interesting. I know you had a final slide regarding the CTs. Okay. Well, maybe I did see some comments about a similar case from Dr. Petroza. Maybe it's worth contacting him to discuss further. But I think in the interest of time, let's move on to our second case. So I will turn it over now to my co-moderator, Dr. Joyce Yu, and she'll present the next case.
Thank you, Dr. Snow. So our next case is just about as confusing and as the first one, actually. So it will be presented by Dr. Rachel Eisenberg. She is a first-year allergy immunology fellow in training at Montefiore Medical Center in New York, and she is being mentored by Dr. Jack Rudy, who's professor of pediatrics medicine, microbiology, and molecular genetics at the Medical College of Wisconsin. So with that, Dr. Eisenberg.
Hi, and thank you for having me tonight. I'm looking forward to presenting this very complicated case. So I'll just go straight into it. Okay, so this patient is, now he's about 18 years old, but he initially presented to us when he was 2 years old, and he had come in with just recurrent otitis media and pharyngitis. By the time he was 6 years old, he had already suffered from about 15 episodes of pneumonia and at one point required chest tube drainage. Again, he had about 10 episodes of otitis media, sinusitis, and tonsillitis. He was also hospitalized once for hepatitis A. He He had a very severe course of varicella infection, and soon into his presentation, he was developing respiratory symptoms and had a CT scan that was consistent with bronchiectasis. And additionally, also soon into his presentation, he had developed autoimmune hemolytic anemia. From the initial onset of his workup, he was started on IVIG for a selective antibody deficiency in the setting of these recurrent infections and bronchiectasis. So his physical exam, which initially presented, was very impressive. He had generalized massive lymphadenopathy everywhere. I listed all the places. He didn't have any rashes or eczema or dermatitis on exam, and he was a healthy kid with a normal height, normal weight, growing well. And really nothing notable on his family history. One of his mother's cousin had autoimmune disease, had lupus, but really in the family there was no other significant autoimmune disease or immunodeficiency. So sort of his initial workup from when he came in, what was very impressive about his lab findings was he had a white count of 100,000, and he also had eosinophilia up to 920. On his immunoglobulins, just pointing out the pertinence, he had a very elevated IgG to 1997, and I put in the values for his age at that time with a normal IgE, and the other immunoglobulins were within normal limits. I wasn't able to find the initial lymphocyte subsets, but there were reports describing it, stating that his CD3 was 50%, and that he actually had elevated CD19 cells. One of his initial Streptococcus pneumonia antibody testing was protective to only 2 out of the 23, greater than 1.3 micrograms per milliliter. Vitamin B12 that was elevated to 1,155, and his initial SPEP per report from notes said that he had a monoclonal gammopathy with a faint kappa band, but his repeat SPEP said no monoclonal protein with just increased IgG concentration. So when he had initially presented with all this lymphadenopathy, he did have a lymph node biopsy as part of his workup, and it showed reactive follicular and paracortical hyperplasia, but no lymphoma markers, and nothing infectious was identified. And again, you'll see in the labs right there, they checked for CMV, for EBV, and really nothing came back as positive. He did have an autoimmune workup by rheumatology initially because of his hemolytic anemia that he was also presenting with, and everything came back normal. He had normal complement levels, C3 of 121 and C4 of 16. His CH50 was also normal, and from his autoimmune hemolytic anemia, he was Coombs positive, and as I mentioned, his viral studies were initially were negative, and from the get-go, I think they were concerned for XLP. That was a genetic testing that was done at a very young age, and that was negative. And again, another thought that was on the top of the differential when he had presented at a young age was ALPS, and the testing at that point was also negative. I also found this in the slide. I wasn't able to find a lab that does this now, but it looks like they just did regular flow cytometry for CD95 and compared it to controls. He had a lower percentage than controls. And he had CF testing in the beginning that was negative, and also when he presented initially right away at age 3-4, he had an ANA of greater than 1 to 640. So some of his pertinent imaging, so again, from 2008, so he was about 8 years old at that point, or 10, he had bronchiectasis. He had diffuse lymphadenopathy with hepatosplenomegaly, with nodules throughout the lung. They were very concerned for a malignant process. He had a PET scan that showed avid lymphadenopathy above and below the diaphragm. They did bronchial cytologies in the beginning because of his recurrent infections, and they were all non-malignant. They were never able to find any positive staining for ASB. Bacterial or fungal stains were always negative. He had an AML FISH panel that was negative, and a bone marrow biopsy that was normal cellular with trilineage hematopoiesis, no tumor seen, no granulomas. And his initial flow cytometry also, you could see the breakdown there, but just to point out, because initially they were considering ALPS, he had 0.4% of CD3 positive double negative T cells, and really nothing, no clonal B cell expansion, because like I had mentioned, with all the lymphadenopathy, he also had somewhat of an elevated CD19, and that was also normal. and he had repeat flow cytometries that were very similar. But his course began to worsen, where he developed worsening splenomegaly up to 18 centimeters in length. And we're going to pause soon after the slide. So with the initial presentation of the autoimmune hemolytic anemia with the bronchiectasis, he was started on corticosteroids and IVIG, and his ITP really did not, sorry, I don't know what happened there. His ITP really did not respond well to the corticosteroids and IVIG, and on one of his notes, I just found impressive how it was described that his splenomegaly was nearing his ACIS. That's how large the spleen was. So he became very resistant to these treatments and was started on rituximab. He had about, I think it was actually 3 courses, and he initially responded very well, but after his second or third time, after the rituximab, his B cells returned to normal percentages, his lymphadenopathy worsened, his spleen enlarged, and he had worsening ITP. And he continued to be admitted very frequently for bronchiectasis flares and for worsening ITP with diffuse petechiae, gum bleeding, and epistaxis. I think I'm going to pause here for some time.
Yes, for sure, definitely. So I think, so you have a kid, again, who has pretty impressive autoimmunity, bronchiectasis, ITP. So anything from anybody from the audience, any ideas as to what he might have, and given the information that we have up to now? Let's see here. Yeah, so I see like a lot of the same kind of differentials for someone who has autoimmunity and sort of a common variable kind of immunodeficiency kind of profile. So LRBA, CTLA4, PI3 kinase. Let's see. So someone is asking. Let's see here. Did we check the uric acid? I don't know if we checked the uric acid on him.
Yeah, I did not see a uric acid check. It wasn't something that I was looking out for. But for LRBA and CTLA deficiency, we hadn't initially sent testing for that or really thought about that because he wasn't hypogam, which I think they usually are hypogam, and he was the opposite with high immunoglobulin, so it wasn't something that was on the initial differential diagnosis. I do know that they were considering caspase 8 deficiency, which we I could just say now ended up being negative. Again, fast sequencing was done, which negative, which we could go through soon also. And his IgM was not elevated.
Okay. Jack, did you have any comments so far?
No, I want to, Rachel, could you clarify, when they did the ALPS panel at Cincinnati, was that they did the sequencing, is that right?
So I think so. That's what it says in the notes, but I wasn't able to find, I think some of his old reports or notes are probably in iron out and not available, so I'd have to get those out. But from the reports, it says that it was genetic testing, sequencing that was done that was negative. And I think he went to an ALPS clinic at, I think it was at the NIH if they had an ALPS center, but I don't recall where it was from the notes, but he went somewhere and had specific repeat testing there done also.
But, and it's important to note that this person is growing fine in contrast to the last case, because initially when I saw this, I also was wondering about gain-of-function stat3, and as Kate pointed out, the gain-of-function stat3s they don't grow well, and this person is fine, correct, Rachel?
Yes, and as Dr. Wu had mentioned before, the opposite of well thriving.
The opposite.
He's like 6 feet tall.
Yes, he is very tall. I think a few other comments, other suggestions for just on the side here. IgG4 related disease was suggested. Maybe Castleman's disease.
Yes.
And then someone maybe leukocyte adhesion deficiency.
For IgG4 related disease, I did see a recent note that was something that they would look into. I didn't hear much more about that. I don't know about Castleman's disease or I don't think leukocyte adhesion deficiency was. Yeah.
And then, actually, just one more question, maybe before we move on to the next section. Someone asked whether a sputum culture was done to see if there's any positive cultures or any pathogens that were identified in the lungs.
No, he did have them. He did have them done, but they were negative.
Okay. All right. Maybe we should move on to the next part of his course.
Sure. So as I was mentioning, he had worsening splenomegaly up to 18 centimeters, and his platelet counts, just in general, from when he was young until now, constantly fluctuating. Sometimes, like you could see, as low as 11,000. And so at that point, because of the massive splenomegaly, he ended up undergoing a splenectomy, and he's now on daily pen-VK. But his postoperative course was very complicated. He ended up having a portal vein thrombosis. He had a TIPS placed, and that became clotted, resulting in portal hypertension. And since then, he really has had a history of multiple thromboses. So I listed some of them there. He had left transverse sigmoid and jugular venous system thromboses in 2011. He ended up having a pulmonary embolus in 2011. He had been on IVIG for a specific antibody deficiency, and that was discontinued due to these recurrent thromboses. He was getting IVIG intermittently as treatment sometimes for the low platelets initially, but that was stopped. And then he was placed on enoxaparin, which as long as his platelets are greater than 30,000. And he really was trialed on many different medications, rituximab, berometplastin, vincristine, all for his ITP, all of which he was refractory to. And he's currently on rapamycin. I think it's been for about a year or two, of 5 milligrams once per day. And he had a very extensive, he's mostly been following up with hematology oncology now, and he had an extensive thrombotic workup that was really negative for, like you see, a comprehensive antiphospholipid screen, all the factor deficiencies, von Willebrand, factor Leiden. So really everything was negative on his thrombotic workup. So just other infectious issues that he had. In 2011, he had presented with myalgias, arthralgias, and fatigue in the setting of eosinophilia, and he was found to be positive to strongyloides and treated twice. But even after that, his eosinophils, which I don't really understand why that's part of his presentation, but his eosinophils tend to rise sometimes as high as 7,200 and then will come down on their own. He gets so that's been one issue for him. He continues to be admitted for frequent bronchiectasis flares. He's had pneumonias that he's been admitted for. He developed a pretty severe rash that was concerning for HSV or VZV that ended up being positive for enterovirus. And most recently, he was admitted to Columbia. He had presented with fever and headaches, and his hospital course was positive for strep pneumonia, bacteremia. He had a clinical meningitis with seizures. He was in the ICU and had imaging that was concerning for small emboli in his brain. So some of his workup that was done from his initial presentation to now, I mean, on his physical exam, he continues to have this sort of diffuse lymphadenopathy. And his CBC, like I'm pointing out, his hemoglobin has been stable, so no issues with autoimmune hemolytic anemia anymore. And on the rapamycin, his platelet counts really range between, like I was saying, 20,000 to up to 600. Even within one month to the next, it can vary that much. And he did have testing that was positive for antiplatelet antibodies. His most recent immunoglobulins I listed here, he's had many done, but they're similar to this with an elevated IgG of up to 3,000. He continues to have poor protection to strep pneumonia with only 3 of 23, greater than 1.3. His mitogenic and antigenic responses were within normal limits. This lymphocyte subset that was done is sort of representative of the ones that were all done recently, so a low CD3 of 46%. His CD4 was 36%. He had declining CD8. Now it's as low as 9%. I think it was even lower on his Columbia admission, with a rising CD19 of 38%. I listed some of his immune work up here, which he was positive to a lot of IgG positive, so maintaining immunity to them. He had HIV testing that was negative, and again, in ALPS panel, and again, I don't know if that one was like sequencing or not, was repeated in 2015 and was negative. He had FAST, so that's gene sequencing, that was negative. They had repeated XLP testing for certain gene mutations that was negative. Perforin granzyme testing that was within normal limits. And then again, caspase 8 and 9 sequencing was negative, and TASI mutation was also negative. So what's interesting from his flow cytometry, so he's had, compared to his initial ones, is that his most recent flow cytometries show 49% of polyclonal B cells. What I sort of bolded here was that he had rising 4% of CD3 positive double negative T cells compared to his prior. He had a bone marrow biopsy done. Again, it was normal cellular and also showed mild eosinophilia on this one. And then another flow cytometry was done in 2013 that had 2.4% of T cells that were CD3 positive with double negative T cells. And he also had, they were really searching for a result for him, MDS FISH panel that was negative, and this was probably done because of his rising eosinophilia, and he was negative for the FIP1L1 PDGFRA. I think we could
so Rachel,
the next slide.
On the pause.
Oh.
Yeah.
Yeah.
So before we get to I know that you had a lot of data, so actually there were lots of questions, just kind of a couple of other questions in the meantime. So I know he got rituximab, and someone was asking, he had rituximab repeated after he had 2 rounds of rituximab, correct? Initially for the, okay, and then someone was asking about the NKT cells. Did anyone check the NKT cells?
I didn't see that.
Okay. And then did anyone check the ADA2 mutation?
I also did not see that anyone checked the ADA2.
Okay. And with regards to the ITP, so Elena was asking, did the splenectomy make the ITP better? But it doesn't sound like it really did, actually, correct?
It did not really make his ITP better. No.
Okay. Let's see here. Let's see. So more people suggesting. Okay, and then STING, gain of function. So there's more suggestions in terms of what could be causing it. Someone was asking somatic ALPS, the possibility.
Yeah.
So let's see. Let's move on to let's finish up the rest of his imaging findings. And what his.
Okay. So yeah, the pertinence from his imaging. So he had an MRI that showed what we spoke about before, thrombosis of the left transverse sigmoid and jugular venous system. He did have an incidental 2-millimeter aneurysm. He had pulmonary embolus, again, a partial, this one I didn't mention before, another thrombus of the straight sinus. His most recent CT showed trine bud nodularity that was most severe at lung bases, that is progressive with a mild bronchiectasis and continues to have mediastinal lymph adenopathy. And again, the most recent MRI showing tiny foci of embolic infarction from his Columbia admission. So I could not go to that one yet if you wanted to discuss more.
Yeah. So,
so what
Jack,
are
any other comments?
Sorry, it's Jack. Rachel, are the PFTs on this person normal? Pulmonary function test?
He had PFTs, and they were more of a restrictive pattern. Oh, sorry. They were more of an obstructive pattern. I didn't put them in here.
Okay.
Oh, hello? Now I'm trying to remember, but I'm going back to what I said before. It was restrictive. It was a restrictive pattern, and he did have while he was on rituximab and while he when he would clinically be improving, obviously he had less bronchiectasis flares and he would have normalization of his PFTs.
And does anyone, when you see trine bud nodularity, you usually think about, it can anything that has to do with small airways. It can be mycobacteria, it can be bronchiolitis, it can be a variety of things. It did, without seeing the CT, it's hard to know, but did radiology have any other comment about that? Did they do an expiratory CT to look for, distribution? Basically you can see air trapping and things like that. Was the patient cultured for MAI and AFB?
He has had a few cultures over his course. I don't know if there was one done around the timing of that CT, but he has had AFBs and cultures done. I saw many results for that, but they were all negative. And I didn't see anything from the CT about expiratory phase imaging.
Is this gentleman overweight now? Is that why he has a restrictive pattern, or was the PFTs done in a body box? Do you know, or did he have complete PFTs? Any evidence of?
I think it was complete PFTs. I haven't actually. I think I met the patient once, but I don't think I would call him overweight. He's just a tall guy, so I don't think that would explain a restrictive pattern. Joyce met him, so maybe.
Yeah, this is Joyce. Yeah, I agree. I don't think he's overweight. He actually seemed, he was just a big, tall kid, but not obese. So do you want to move on to so a lot of questions. We're not sure exactly what he has. Oh, someone's asking, has he had a ciliary biopsy? I don't know if he did that.
I don't recall seeing that he had a ciliary biopsy.
Okay. But I'm not sure. Okay.
Sure, I can do that.
So maybe we're not exactly sure what he actually has. So I think here. Any comments? Any other ideas?
Oh, are you asking me?
Yes.
Oh, so some of the differential that we were thinking of, and just from reading up, but I'm sure everyone here knows a lot more about this than I do. There are the common genotypes for ALPS, and it seems like FAS is the most common mutation for ALPS, and then more rare is FAS ligand and the caspase defects. But it says that up to 20% of patients that have clinical ALPS remain genetically unidentified, and he did have many of the findings that you would see with a clinical ALPS. So I'm trying to. He had a chronic non-malignant lymphadenopathy, and he did have, which was what was kind of confusing for me, and I thought maybe someone can help answer this question, is that sometimes he did have the elevated CD3 TCR alpha beta that positive with the double negative T cells, which are you're supposed to have greater than I think it's 2.5%, and he had that. He didn't have that in the beginning, and now when he had flow cytometry done, it was present, and I don't know if that's a usual thing to change. And then from the workup also, it talks about having the defective lymphocyte apoptosis, which he never really had, and he never really had the genetic testing, but he did have the elevated vitamin B12 levels, which I threw in the beginning just to think about, and he has the autoimmune cytopenias with the increased IgG levels. So he really does fit a clinical picture of ALPS more so than some of the other diagnoses that were mentioned. I don't know what people think about that.
Definitely.
So, you've really nicely articulated that he fulfills the clinical criteria. So today there are published clinical criteria for the diagnosis of ALPS. And so you're very right to point out that he does fulfill those criteria. And although the double negative T cells have waxed and waned, at various points he's clearly fulfilled the clinical criteria. And I would just remind you of a couple of things. One is that the somatic mutations, which a couple of people have correctly pointed out, do tend to have waxing and waning double negative T cell populations. And the way you classically make that diagnosis is to sort and sequence just the double negative T cells. And the other thing I would say is remember the very first publication on PIK3CD deficiency was that it had an ALPS phenotype and it looked like lupus. So when you have this kind of infection ALPS combo, do always think about the PI3 kinase category.
Okay,
Great,
so that's something
idea.
else too. Yeah, I'm writing everything down.
I know you had another
mentioned
show, right?
Oh, yeah, this slide was just mentioning some of the suggestions that everyone made, and I sort of tried to point out why he didn't really fit into some of those clinical pictures as well as he does into a clinical ALPS. But I guess for the sake of time, do you want me to go on to the sort of questions to help manage this patient?
Yes, definitely.
So the first question is kind of what we discussed already. So would one consider this ALPS despite negative genetic testing? Another question that we sort of touched upon was, can the percentages of the CD3 double negative T cells fluctuate in time in a patient with ALPS, as was seen in our case? But the sort of more complicated questions is how to manage this patient. So he is currently not on any IVIG therapy, and he has been admitted for several infections recently and a pretty severe case at Columbia with this bacteremia and meningitis, and sort of how to manage his immunodeficiency when he has this high risk for thrombosis, and what people, some suggestions of how people would manage him, and sort of the workup. Would you, other than the PI3 kinase that we spoke about, and doing the sequencing for double negative T cells, look for the somatic mutations that you mentioned, but how much further should we be digging to come up with a diagnosis for this patient? He already did have a whole exome sequencing in 2013 that came back negative pretty much.
I think NIH will do a flow cytometric evaluation for the PI3 kinase defects, and I can't remember exactly what it is, but I think it's something immediately downstream of mTOR. I think it might be AKT phosphorylation, and they have a flow-based assay. Jack, do you remember?
Yeah, it is. It's phospho-AKT. We tried to get that assay going. We never could get it, but Tom has said that is their screen. And so the thing that sort of that is unusual for PI3 kinase delta would be, usually if when you look at their immunoglobulins, they can have a dysgammaglobulinemia, but typically their IgM is elevated. And when you look at B cell subsets, they really have defects in a variety, but most commonly in markedly decreased switch memory B cells as well. The ones that we saw had, we've got 7 or 8 now that they all had dysgammaglobulinemia, either borderline high or high IgMs and virtually no switched memory. So I think the idea of sequencing the double negatives is a great idea. I have personally followed flow on patients that have had germline mutations in FAS, and double negatives really can vary for whatever reason. They can be normal or they can be elevated.
Oh. So what do you guys think about this thromboses? Do you think it seems very severe in this particular case? It says do you think it's going to complications, for example, if he was going to get a bone marrow transplant or something like that?
I know that just before the answer, I know that he was evaluated for bone marrow transplant, and part of the reason he didn't have a good match at that time, but part of the reason why they also didn't feel like he was a great candidate was because of all of his other medical complications.
Okay.
I do worry about, he's had a lot of pretty significant infections over this course, and I guess one question that you might want to consider is if, whether or not you brought it up earlier, in the interim you want to restart gamma globulin therapy. And I personally wouldn't give IVIG, but you might want to consider, subcutaneous. And with the IgG that high, if you have them on gamma globulin, then you could always, reinstitute rituximab therapy to get rid of some of his B cells, which are elevated now again. So, I just worry about while you're going to repeat an exome, whether or not you in the interim want to, try that at least.
I think that he is approved for HyQvia. We're hoping that the patient shows up. He's not easy to follow up with.
All right. So,
at Montefiore.
yes. Exactly. So we're basically 7 minutes over. So I think probably about time to end the webinar. Thank you everyone for coming. There was two great cases. And again, if anyone has any interesting cases that they would like to present, please submit them to the CIS office, and we'd be happy to consider them for presentation. All right. Well, have a good night, everybody.
Thanks.
Thank you.
Thank you.